All right, if you're a PA student cramming for the PANCE, you've come to the right place. This is going to be a super rapid-fire, high-yield review of chronic stable angina. We're talking the absolute bread and butter of coronary heart disease. We're going to cut right to the chase and focus on what you actually need to know to crush your boards. Okay, let's get into it.
So let's kick things off with a question you're pretty much guaranteed to see in some form. How do you spot angina just from what the patient tells you? I'm telling you, this is a critical skill. So we're going to break it all down. We're going to follow a patient from their story through the entire workup and all the way to their treatment plan.
First things first, the history. Honestly, more than any fancy test, it's the patient's story that nails the diagnosis of angina. So when you get a question on your exam with a long patient story, lean in. All the clues you need are hidden right there in the text.
Now, this might look like a boring old textbook definition, but don't skip it. This thing is an absolute goldmine for your boards. It breaks down into 3 super high-yield parts. 1, it's chest pain. 2, it's brought on by stress or moving around. And 3, it gets better with rest or nitroglycerin. You see those 3 things together? Your brain should immediately be screaming stable angina.
But here's a little pro tip that's also super testable. Patients almost never use the word pain. They'll say things like squeezing or tightness, or they might even think it's just bad indigestion. And hey, if a test question describes a patient literally clenching their fist over their chest, that's a Levine sign, and it's practically a flashing neon sign for myocardial ischemia.
Okay, so the story has you suspicious, but you can't just go on a hunch, right? You need some cold, hard evidence. So let's talk about the workup, starting with the ECG and moving on to the stress test. Listen up, this is a massive point for your boards. A resting ECG on a patient with stable angina is usually completely normal. Let me say that again, a normal ECG does not rule out coronary artery disease. The real magic happens during an episode of pain. That's when you see it, the horizontal or downsloping ST segment depression. That's the classic textbook sign of subendocardial ischemia.
So if that resting ECG is normal, where do you go next? What's the best initial test? For any PANCE question, the answer you're looking for is the exercise ECG, the good old-fashioned stress test. It's the most common first move to see if we can provoke that ischemia.
And as you're staring at that stress test report, what are you looking for? What makes it positive? Here it is. Burn this number into your brain. Greater than 1 millimeter of horizontal or downsloping ST depression. That specific measurement is the classic high-yield answer you need to know.
Okay, so your stress test comes back positive. You've now proven there's ischemia. So the next logical question is, well, where's the blockage? It's time to actually get a look at the coronary arteries themselves.
And this brings us to another one of those key buzzwords. When a question asks for the definitive or the gold standard test for diagnosing CAD, the answer is always coronary angiography. Now, it's invasive, so we don't do it on everyone, but to get the final answer, this is it. So during that angiogram, what's the magic number we're looking for? It's 70%. A blockage, or what we call a stenosis, is generally considered bad enough to cause problems and need an intervention once it blocks more than 70% of that artery.
So we've nailed the diagnosis. We know exactly where the problem is. Now, let's fix it. The management plan is basically a 3-pronged attack. How to handle an acute attack, how to prevent future ones, and for some people, how to physically open up the blockage. For an acute angina attack, the protocol is simple and super testable. Step 1, 1 nitroglycerin tablet under the tongue. If the pain's still there after 5 minutes, take a second one. Still there after another 5, take a third. Now, if 3 doses in 15 minutes haven't touched the pain, that's a medical emergency. Time to call 911 because this could be an MI.
Okay, so how do we stop those attacks from happening in the first place? This is all about long-term medical therapy, and it really rests on a few key classes of drugs. Think beta blockers, nitrates, and antiplatelets.
First-line therapy for chronic angina, beta blockers. And if you remember one thing about beta blockers, make it this. They are the only anti-anginal drugs proven to actually reduce mortality and prolong life in patients after they've had a heart attack. That's a huge deal. That's why they're number 1. Next up, long-acting nitrates. 2 things you absolutely have to know here. First, patients develop tolerance, so they need an 8 to 10 hour nitrate-free break every single day to make sure the drug keeps working. And second, and this is a major safety alert for your boards and for real life, nitrates are a huge no-no if a patient has recently used a PDE5 inhibitor like sildenafil. That combination can cause a catastrophic drop in blood pressure.
And finally, every single patient with known coronary artery disease should be on 2 other meds unless there's a really good reason not to be: a baby aspirin every day and a statin. These are the foundation of risk reduction. If they can't take aspirin, the go-to alternative is clopidogrel.
Now, when meds aren't cutting it or the disease is really bad, we start thinking about revascularization, basically plumbing. The 2 main options are PCI, which is stenting, and CABG, which is bypass surgery. For your boards, just keep it simple. PCI is great for simpler disease, like 1 or 2 blocked vessels. CABG is for the really complex stuff, like 3-vessel disease or a blockage in the big one, the left main artery.
But if there is one specific scenario you absolutely must associate with CABG, it's this one right here. The famous FREEDOM trial totally changed the game. It proved that for patients who have both diabetes and multivessel disease, CABG is way better than PCI at preventing death, heart attacks, and strokes. This is an incredibly high-yield point.
Okay, let's wrap this up. What's the big picture here? What's the modern way we think about treating stable coronary disease, and what does the future hold for these patients?
This is pretty cool. We can actually put a number on a patient's risk. The Duke treadmill score is a neat little tool that takes info from the stress test, like how long they lasted and how much ST depression they had, and spits out an annual mortality risk. If you get a high-risk score, say less than -11, that patient has a 5% chance of dying in the next year. That's someone you're probably sending for an angiogram.
And this right here is probably the most important modern concept in stable angina. Big landmark trials like Courage and Ischemia have shown us something really surprising. For a stable patient, putting in a stent doesn't actually make them live any longer than just being on the right medications. Interventions are amazing for getting rid of symptoms for sure, but when it comes to living longer, the medical therapy is the real lifesaver.
So we'll end on this question. Is physically opening that blockage always the best move? Well, for stable patients, the evidence is pretty clear, not for survival. The main takeaway is that aggressive medical therapy, your beta blockers, your aspirin, your statins, that's the powerful, evidence-based foundation of treatment that truly changes the game for these patients. And that's the bottom line. Good luck on the PANCE.